Module 3, Treatment Strategies. This module will review selected biologic-based therapies given to patients with severe asthma based upon their select phenotype and endotype. We will also be discussing optimal treatment regimens based upon asthma severity and comorbid conditions. Joining me now, Dr. Michael Wechsler. Dr. Wechsler, what are the strategies that we can use to maximize standard therapies for patients with asthma?
In terms of maximizing standard medical therapies, it's important to recognize the importance of the environment as well as adherence and comorbidities, and then to recognize that we have novel therapies that can address our unmet needs. First of all, it's important to recognize the role of the environment. Allergen avoidance is really key in terms of identifying strategies that can help our patients with asthma. Patients who are allergic to cats should avoid cats. Patients who have occupational allergies should try to avoid those or mitigate those to some extent to prevent deleterious effects on their asthma. Management of comorbidities is also really important. Addressing chronic rhinosinusitis, gastroesophageal reflux disease, vocal cord dysfunction, sleep apnea, all can help address issues associated with asthma. In addition to avoiding environmental allergens, allergy immunotherapy, or allergy shots, have been shown to be quite effective in terms of ameliorating asthma symptoms. As well, we now have the availability of a variety of different biologic therapies for the management of asthma. Anti-IL-5 therapies, including benralizumab, mepolizumab, and reslizumab, have all been shown to be effective in patients with eosinophilic asthma. Anti-IgE therapy, including omalizumab, has been shown to be effective in patients with allergic asthma. And on the horizon is anti-IL-4 receptor alpha therapy, including dupilumab, that's been shown to improve lung function and reduce asthma exacerbations in patients with type 2 asthma, including both allergic asthma as well as eosinophilic asthma. In addition to all of these therapies, we also have available to us bronchial thermoplasty. Bronchial thermoplasty is an effective treatment strategy for patients who have severe asthma, as it's been shown to reduce asthma exacerbations, emergency room visits, and hospitalizations. It's a therapy that involves delivering thermal energy or heat to the airway walls using a catheter delivered bronchoscopically. The catheter heats up the airway wall and reduces airway smooth muscle and improves asthma exacerbations.
What is your approach to treating patients with severe asthma?
My general approach is to treat patients with the most appropriate therapeutic strategy, to identify a personalized approach so we can give the right drug to the right patient at the right time. To do this, I try to identify the type of asthma that the patient has. And you can do this by looking at both phenotypes or endotypes. The goal is to try to treat based on an underlying asthma mechanism of inflammation. So my strategy generally involves identifying patients based on whether or not they've got type 2 inflammation or non-type 2 inflammation, and then identifying whether they have elevations in eosinophils, nitric oxide, or IgE. I also use surrogate measures of asthma endotypes that look at particular phenotypes. So patients who've got allergies often have IgE-mediated disease. Many patients that have chronic rhinosinusitis often have IL-5 or IL-4-mediated disease. And patients who've got atopic dermatitis also often have IL-4-mediated disease. The goal is to try to use the most appropriate therapeutic strategy in the right patient at the right time. So what can we achieve with biologics?
Over the past 8 to 10 years, we've seen a number of different outcome measures improve markedly with a carefully and appropriately chosen biologic medication. Because these drugs are expensive and they require an injection in the office, we want to choose wisely. And we want to choose patients who are in the greatest need of this kind of a drug. And this would imply typically that a patient has multiple exacerbations per year, typically at least 2 or more that required a course of oral corticosteroids to bring the disease under control. And what we have seen with biologic medications, whether it be omalizumab or the anti-IL-5 drugs or dupilumab, is that they do reduce exacerbations significantly. With some but not all of these drugs, there's been marked reductions in oral corticosteroid requirements. And what comes to mind are the drugs mepolizumab, benralizumab, and dupilumab have all published data indicating that there are significant reductions in oral steroid requirements, while at the same time, a much better improvement in overall disease control with fewer exacerbations. We shouldn't just think of exacerbations, however, although they are very important, but we should consider the daily burden of disease and quality of life that's impaired by having asthma. And in this situation, what we can expect to see is less asthma symptoms, better quality of life, and with better quality of life, the things people want to do. Better sleep, better exercise, and better ability to stay and work effectively at their job. And then finally, something we look forward to, and at this point in time, we can't say that we've achieved it, although I think long-term studies with new biologics may bear this out, is a reduction in long-term airway remodeling. This is actual disease modification, or maybe even disease remission. And now with drugs such as the IL-5 antagonists, as well as the IL-4 receptor antagonists, we may in fact achieve that. I have a couple of questions. First, which therapy is best for a specific patient? And then secondly, how do you choose between biologics?
I generally use biomarkers to help predict therapeutic responses. Biomarkers like eosinophils in the blood or in the sputum, nitric oxide, IgE levels, for instance, are all useful biomarkers. We clearly need other biomarkers, and other biomarkers are in development. Biomarkers like periostin and DPP4, or dipeptidyl peptidase 4, are also in development that may help us decide which strategies are useful for which patients. In general, I try to phenotype patients and choose the most appropriate therapy. So if someone has predominantly allergic asthma, I'll use anti-IgE. If someone has predominantly eosinophilic asthma, I could use either anti-IL-5 or an anti-IL-4/13 therapy if it's available. If someone's got an elevation in nitric oxide level, an anti-IL-4/13 strategy is probably the most appropriate therapy for that patient. Our goal is to provide a personalized precision medicine approach, and our goal is to try to identify biomarkers that can predict specific endotypes in a given individual. In addition, I sometimes use phenotypes to help me decide which endotype is most likely to occur. So if someone has concomitant atopic dermatitis, I'm more likely to use a drug like dupilumab that targets IL-4/13. What are the long-term health risks with biologic therapy?
One of the ways of answering this question is to examine a biologic medication that we've had available to us for the past 15 years, and that is omalizumab. There have been some excellent long-term open-label studies of this drug, and what we've been able to glean from these studies is that the drug appears extremely safe. The other biologics that we have available to us, particularly the anti-IL-5 drugs and the anti-IL-5 receptor drug, mepolizumab, rosalizumab, and benralizumab, there have been one-year follow-up studies, and with mepolizumab, an even longer period of observation. And thus far today, we have not found any long-term health risks of using these drugs for prolonged periods of time. It may be in the future that something will become discovered, but at least at this point in time, I think we can rest assured that these are safe medications with adverse events very comparable to placebo.